Now that we've talked a little bit about heart sounds, it's important to cover the idea of splitting. Like we talked about, the S1 sound normally has both the mitral and tricuspid valves in it, and the S2 sound normally has both the aortic and pulmonic valves in it. Splitting occurs when S2, which is normally a single sound, is split into two separate sounds. The key to understanding why this happens is thinking about valve closure. Anything that causes the pulmonic valve to close later will lead to splitting. This can be physiologic, like during inspiration, where more blood flows into the lungs. However, it can also be pathologic. For example, any condition that delays right ventricle emptying will lead to a worsened splitting throughout the breathing cycle. Also, a fixed anatomical lesion, like an atrial septal defect, will lead to a splitting that does not vary with breathing. The last type of splitting is different than all the rest because in this case the aortic valve closes first due to delayed left ventricle emptying. As a result, the splitting actually goes away with inspiration, which is why it's called paradoxical. All of that information about splitting really isn't that helpful without the context of cardiac auscultation. This is probably something that will seem familiar from your physical exam courses, and most of this information can be memorized, including the table of maneuvers. You should remember where the auscultation points are: aortic, pulmonic, tricuspid, and mitral, spelling out apartment M from top right to bottom left. As far as the bedside maneuvers, there are a number of simple things that a patient can do to either increase or decrease the intensity of various heart sounds and murmurs. This information is well suited to memorization, so please spend some time mastering this table. Now let's move on to heart murmurs. This information is absolutely critical for the exam, which now has audio questions to test your ability to identify heart murmurs. Of course, it's impossible to learn everything about heart murmurs in one page, but the ones listed here are those that you're most likely to encounter on your exam. Let's start with the systolic murmurs. The first one is mitral regurgitation and/or tricuspid regurgitation. Notice how this sound goes all the way from S1 to S2, meaning it is holosystolic. If you hear this sound loudest in the mitral area, it would be mitral regurgitation, and if it's loudest in the tricuspid area, it would be tricuspid regurgitation. Next, let's listen to aortic stenosis. Even though this sound is also systolic, it sounds a lot different. It doesn't go all the way from S1 to S2, and there's a little gap on each end of the murmur. Plus, it's not the same the whole way through, but it gets louder and softer, also known as crescendo-decrescendo. This sound would also be heard best near the aortic area. The next systolic murmur is from a ventricular septal defect, or VSD. This will sound a lot like tricuspid regurgitation, and it's usually heard best in the tricuspid area, so this can cause some confusion. One easy way to distinguish the two is that tricuspid regurgitation will become louder as the patient breathes in, while a VSD murmur shouldn't change with the breathing cycle. The last systolic murmur to go over is mitral valve prolapse. This is when the mitral valve prolapses slightly into the left atrium during systole, causing a sharp mid-systolic click followed by a late systolic murmur. This one is easy to tell from the other systolic murmurs because of the sharp click. Even though the first four murmurs we've talked about are all systolic, the details will help you tell them apart. Now let's look at the two diastolic murmurs. The first is aortic regurgitation. This is a diastolic murmur that starts immediately after S2, gets quieter, and ends before S1. It's also best heard in the aortic area. The second diastolic murmur is mitral stenosis. This murmur is preceded by an opening snap in diastole. Then it has a rumbling quality that lasts until the next S1. It's heard best at the mitral area. These are really the only two diastolic murmurs that you'll need to know, and they're easy to tell apart by the location of where they are best heard and also by the presence or absence of an opening snap. The final murmur to talk about is a patent ductus arteriosus, or PDA. When people say that this murmur is machine-like, they aren't kidding. It really sounds like a washing machine or a dishwasher. Most importantly, though, it lasts throughout the entire cardiac cycle, systole and diastole, which easily sets it apart from other murmurs. Great. Now, we're going to switch gears and move on to talk about the electrical activity of the heart. If you need a break, now is a good time. Go to the bathroom, grab a snack, whatever you need. I'll be here when you get back. We're now going to start talking about the electrical activity of the heart by talking about ventricular action potential. The different phases of the cycle are listed here. Phase 0 consists of a rapid upstroke mediated by voltage-gated sodium channels. Phase 1 is an initial polarization where these sodium channels become inactivated and potassium channels start to open. Phase 2 is a plateau phase mediated by calcium influx through voltage-gated calcium channels. Phase 3 is a rapid repolarization triggered by massive potassium efflux out of voltage-gated potassium channels. And finally, Phase 4 is the resting potential, primarily driven by high potassium permeability. The biggest difference between this action potential curve and the one for neurons, which is covered in greater detail in the neurology section, is that in heart cells there is the Phase 2 plateau of action potential. Again, this is caused by calcium influx, which balances potassium efflux. This is especially important because the plateau phase allows for coordinated myocyte contraction. This is necessary for the pumping action of the heart to work properly. Another important difference is that cardiac muscle cells are electrically coupled to one another by gap junctions, so that depolarization in one cell spreads to adjacent cells, allowing for coordinated contraction. As you can tell, the differences in cardiac muscle are important because they allow the entire ventricle to contract in sync, whereas skeletal muscle fibers often contract separately to allow for fine movement. This type of action potential shown here occurs in all ventricular myocytes, as well as in the cells of the conducting system, such as the bundle of His and the Purkinje fibers. The next diagram walks through the pacemaker action potential curve. This occurs only in the sinoatrial and atrioventricular nodes, also known as SA and AV nodes. And there are some key differences between this potential and the ventricular action potential we just saw. The biggest difference is that these cells are responsible for initiating cardiac contractions, so they need a way to depolarize regularly without relying on outside input. So, during Phase 4, there is a slow depolarization caused by sodium flux. This leads directly to the rhythmic contractions of the heart. Additionally, in this case, the Phase 2 plateau is absent, because these cells do not need to contract in unison since they don't contract at all. The next page is the beginning of our discussion of EKGs, or electrocardiograms. This is a very high-yield topic on the exam. There are entire EKG textbooks out there, but these pages will contain the basics of EKGs that you will need to know for the exam. Let's go through the first fact while looking at the picture. This is the basic tracing of an EKG, which records the net electrical activity in the heart. The P wave represents atrial depolarization. The QRS complex represents ventricular depolarization, and the T wave represents ventricular repolarization. If you're wondering why there isn't a wave for atrial repolarization, that's because it's overshadowed by the QRS complex. Some important segments and intervals to know are the PR interval, which represents the period between atrial depolarization and ventricular polarization when the impulse is being conducted through the AV node, the QT interval, which represents the period of mechanical contraction, also known as systole, and the ST segment, which is normally isoelectric and is especially important because any changes here can indicate serious cardiac events. These are the basics of EKGs. There are a lot of other details on this slide, especially about the conduction system of the heart. These are very important to know, but they are also quite suitable to memorization, so please make sure you spend the time to learn these details.